Factors affecting safety include developmental considerations, patient environment, functional ability. So always know the factors that are affecting the topic that we're discussing. So developmental considerations begin on page 838. I would suggest that you read through it. It actually goes for several pages. However, special attention to teaching tips 28-1, which is on 839 and 840. Under neonates, it mentions use of the car seat when transporting the infant, and you want to make sure that the car seat is in the back seat facing rear. Okay, so that's an important safety tip that you would need to teach the parents. At the hospital, they won't even discharge the child if, in fact, the parents do not have a car seat. So newborn infants will not be discharged without a car seat. It is considered unsafe discharge. Also, the last bullet under neonate mentions having the infant to sleep on their back or in a prone position. So those two are important to know. I would suggest that you read through them all and make sure you have an understanding of them all. Patient environment begins on page 852, and it talks about the work environment, the social environment, the home environment. So I would read through those, make sure that you understand those, and then we have functional ability, which begins on 854. And that speaks about mobility, sensory, ability to communicate, knowledge, and health, or that physical health state and psychosocial state. And at the very bottom of 855, it gives you some examples of actual and potential health problems and needs related to safety and security. Our developmental considerations are broken down according to age. And in our book, it does have a paragraph that explains specific considerations for each different age group. So for our neonate and infants, so we have different fetal considerations, as I mentioned, safety with the infant sleeping on their back, the car seat being properly placed rear facing, washing your hands, not leaving the infant unsupervised, supporting the infant's head. Toddler and preschooler, so you don't want to leave them unattended or unsupervised. You want to watch them closely to prevent injury, poison control. So you want to make sure that the parents know they should have the poison control number handy in the event that they will need that at home. If something occurs. In addition to that, on page 842, it speaks about emphasizing to the parents or the caregivers to call poison control immediately if an event occurs before attempting any home remedies. The parent or caregiver must be instructed to bring the child immediately to the emergency facility for treatment. So the parent should not attempt home remedies. The parent should call poison control immediately, follow their instructions, and bring the child to emergency department immediately if, in fact, they suspect that the child has been exposed to something that's poisonous or some type of chemical may have been ingested. Fixation. There's a paragraph on that in page 842 as well. Suffocation or asphyxiation may occur at any age, but incidents are greater in children. And then child abuse. So we are mandated reporters. If abuse is expected, then we as healthcare providers must report it and allow the investigation to be done by those who are qualified and those who are deemed or with their responsibility to do that. So protecting the child is also being alert to manifestations that indicate the child's maltreatment and abuse. And then it talks about box 28-2. So I was just reading from page 842. In box 28-2, it gives you signs of physical, sexual, emotional, and neglect, different types of abuse. I would read through those and be familiar with those. That sounds like something that's important that someone may write a question about. So, developmental considerations for the school age child. So, that begins on page 843. So, the child should wear a helmet at all times when riding bikes. Young children who have a secure child seat on a bicycle should also wear a proper sized helmet as well. Chin strap should be on that helmet. On 839, it speaks about some teaching tips for the parents in regards to the school age child. So read through those. And they list, so that was a reference to preventing accidents for school age child. Then we have a paragraph about child abduction on page 844, as well as bullying, page 844. Moving into adolescence. So for adolescents, driving is the biggest concern. So that's on 845. And the CDC lists motor vehicle accidents as the number one cause of death for adolescents. Teenagers 16 to 19 are 3 times more likely to have a fatal crash than drivers older than the age of 20. So that is important to know. I want you to know that. So substance abuse and misuse is an issue at this age. So on 845 is where adolescents begin. And then we have tattoos and piercings, internet and social media. So these are all safety concerns for adolescents, as well as sex trafficking. So on 847. Nurses must be aware of the indications of a concussion. So this is on page 844. It breaks it down into 4 different categories. There's four bullets in the middle of the page. So we have physical, cognitive, emotional, sleep. So it is my recommendation that you know what are the physical signs, what are the cognitive or mental signs, what are the emotional signs, and what are the sleep signs. So I believe, if I recall, you had to identify the signs of a concussion in relation to the different aspects and not just know the signs of a concussion. So nurses in a variety of studies need to be alert for indications of a concussion. And this is necessary so that they may call 911 immediately and get this child to the hospital or to the emergency department for attention. All right. Physical signs include headache, vomiting, problems with balance, fatigue, dazed, or stunned appearance. Cognitive involves mental fog, um, difficulty concentrating and remembering, confusion, forgets recent activities. Emotional involves irritability, nervousness, very emotional behavior. Sleep involves drowsiness, difficulty falling asleep, sleeping more or less than usual. So know all of these. So developmental considerations for the adult begins on page 847. It includes drug use and poisoning and intimate partner violence, or IPV. Continues on to page 848. In box 28-4, it has a screening instrument used for domestic violence or intimate partner violence. And then on 849, older adult begins. And then it talks about falls, talks about motor vehicle accidents, as well as on page 851, it continues, it talks about fires, polypharmacy and poisoning, and elder abuse. On page 850, we have a table, and it's 28-1, which mentions the risk factors for older adults in reference to falling, and it has intrinsic and extrinsic environmental factors. I would know these because older adults are definitely at risk for falls, in addition to when they come to a nursing home or a rehab facility, they're at a higher risk for falls due to a new surrounding and not being orientated to their new surrounding. And often they are watched very closely for those first few weeks. A fall assessment is done weekly to prevent any falls from occurring. So being orientated to their room and to the call bell usage is very important, and to their environment is very important for safety for the older adult when they are admitted to a new facility. If you turn to page 857, it speaks in reference to admission to a new facility. At the bottom of 857 on the left-hand side, as a part of the hospital admission routine, orientate the patient to the safety features and equipment in the room. I'm at the top of 857 on the right-hand side. An explanation and the demonstration of the adjustable bed, side rails, call system. Call system refers to the call bell. Okay, so you need to orientate them to the usage of the call bell when they need assistance. Telephone, television, bathroom, help the patient to adjust to their new environment. So orientating them to these features will help them adjust to the new environment and prevent falls and keep them safe. Important to know. Okay, you must know that. Safety consideration for adults. Remind them of effects of stress on lifestyle and health. Enroll in defensive driving course. Counsel about unsafe health habits such as drug and alcohol use. Evaluate workplace for safety. Counsel about domestic violence. Safety plan for victims of domestic violence include safety while living with a abusive partner, safety planning with children, safety planning for pets, safety planning during pregnancy, and leaving a relationship. All right, safety considerations for older adults. So on page 857, it begins to talk about our older adults, and it's 3 questions that healthcare facilities are encouraged to ask, and that is, have you fallen in the past year? Do you feel unsteady standing or walking, or do you worry about falling? Are you worried about falling? There's something called a sentinel event. I want you to know exactly what that is. So a sentinel event is an unexpected occurrence involving the death or serious physical or psychological injury or the risk of death or injury. So it starts on page 857 at the very bottom and goes over to page 858. So please know what a sentinel event is. At the top of 857, it talks about orientating your patient to the healthcare facility, which we talked about on the previous slide. Then on page 858, it has 4 bullets from the Joint Commission that actually talks about how to reduce the risk of falls and harm to a patient in relation to falls. All right, on page 859, it starts to talk about restraints. So I'm going to mention this now because we're talking about identifying safety hazards in the environment. So a restraint, we have chemical restraints, which is any drug that is used to control a behavior and that is not a part of the patient's medical regimen is considered a chemical restraint. So you have a patient that's wandering at nighttime and now you're giving them a medication to help sedate them so that they won't wander at nighttime. That is considered a chemical restraint. Our job is to monitor them and make sure that they are safe if they're up wandering at nighttime and not to sedate them. Okay. And on page 859, it talks about chemical restraints. Then at the top right hand side of 859, it talks about the unbus budget reconciliation, and it encourages a limited use of restraints in long-term care settings. So our goal is not to utilize restraints in a long-term care setting. This is their home, okay? And in the event that a restraint is required, we must have a written consent from the responsible party, and all other means of keeping this patient safe has been exhausted at that point. Okay, so it is discouraged to restrain a person in a long-term care setting. Okay, very limited use, if any at all. However, in acute care setting, they may utilize a restraint more often, more frequently. Um, so the current standards for long-term care facilities provide safe care without the use of physical or chemical restraints. That is the current standard. Federal and state mandates as well as JCO, and they recommend that acute care facilities use restraints only as a last resort. And that's all on page 8. All right, so back to our slide, second bullet. So you want to modify their environment as necessary. So make sure their belongings are within reach. Make sure they have their call light and it's functional and they understand how to function it. Non-hit socks. If they're using a commode, make sure that they have access to get to the commode, or they need assistance to the bathroom. We are providing that. Attend defensive driving courses for older adults if necessary. Encourage regular vision and hearing tests. Ensure hearing aids and eyeglasses are available and functioning. Have operational smoke detectors in place, as well as objective documenting and report any signs of neglect or abuse. Okay, this is considerations for our older adult safety. Okay, we have a question. Among older adults, fires are the leading cause of injury and fatality. True or false? And the answer is false. So, among older adults, falls are the leading cause of injury, fatality. So please recognize that we did spend a lot of time speaking about falls on the previous slides. However, I did not mention it is the leading cause of injury, fatality, and this is important for you to know. Patient environments begin on page 852, and the 3 subcategories include work environment, social environment, and home environment. Functional ability and health. So functional ability begins on page 854, and it divided into 4 subcategories, which include mobility, sensory perception, ability to communicate, and knowledge. So I would suggest that you are familiar with all of those. And on that same, 855 is where health begins. So we have our physical health state and our psychological or psychosocial health state. Assessing fall risks in older adult. So assess the history of falls or accidents. So you want to ask, have they had any falls in the past year, right? Note any assistive devices that are being used. Maybe they use a rolling walker, a rollator, which is basically like a walker that has a seat to it. Maybe they also may have a cane. So any assistive devices, they could have a wheelchair. Be alert to history of drug or alcohol use, because that places this patient at higher risk for a fall. Obtain knowledge of family support system and home environment. Okay? And you want to just make sure that the patient, do a fall assessment, right? And make sure that you're assessing for their risk factors for falls. If they are at risk for a fall, you must write a plan of care addressing that risk of fall. What are we going to do to keep them safe and prevent a fall? And you also have to put these interventions that's on your plan of care in place. Otherwise, this is going to be a deficiency, right? Because we neglected to meet the needs of the patient and maintain the patient's safety, even though we knew this patient was at risk for a fall. All right, here are some common factors that contribute to falls. So I would know this because as a nurse, you need to be able to not only assess your patient and determine that they are fall risk, but you need to be able to kind of just eyeball a patient and recognize they're at risk for a fall, right? They're at risk for injury. Or reading through a chart, recognize certain things, they're at risk for a fall, they're at risk for injury. So if you see poor gait or balance, strength issues, visual impairment, even if they wear glasses and they can see with their glasses, they're still at risk for a fall because there's a possibility that they may not be able to locate their glasses, or maybe the glasses fell off or they're broken, so they're at risk for a fall, right? Problems with feet. So maybe they have a wound on their feet, or maybe they have some stiff joints or pain in their lower extremities. Comorbidities, use of medications that increase a fall risk. So you need to understand medications that will increase the risk of falls. So any type of blood pressure medication could cause them to bottom out, become hypotensive, anything that's sedating, anything that will cause them to go to the bathroom frequently, like a diuretic. These types, it's multiple different types of drugs that could cause a fall or increase the risk of a fall. Orthostatic hypotension. So we talked about that before in class. So when the person changes position, usually from a lying to sitting, a sitting to standing position, their blood pressure drops. And it usually drops by at least 20 um, millimeters of mercury. Okay? So this is considered orthostatic hypotension. These patients become dizzy as they are changing positions, and sometimes they fall or faint in regards to their blood pressure dropping so quickly. Hazards in the home or community, such as like throw rugs. So throw rugs would be removed, or you would educate them that that is a fall hazard and it should be removed for older adults. Or just excess clutter. You want to make sure that they have a well lit room. So certain things you as a nurse will come to know as safety measures for your older adult, just as a second nature. Vitamin D deficiency can also contribute to falls. Okay, so we have a question. A nurse whose behavior is reasonable and prudent and similar to the behaviors that would be expected of another nurse in a similar situation, is still likely to be found liable if a patient falls. True or false? Answer is false. A nurse whose behavior is reasonable and prudent and similar to the behavior that would be expected of another nurse in a similar circumstance is unlikely to be found liable if a patient falls, even if its injury occurs. So, this is basically saying that they did a fall assessment or they assessed the patient and deemed this patient as a fall risk, so they put interventions in place, they put the care plan in place, everyone's educated, they're aware that this patient's at risk for falls, and somehow the patient falls again. Falls anyway. This nurse is not liable because she has done her part. She's done her due diligence, right? She's done the right thing, or deontology. She put the interventions in place. She put the plan of care in place. Those who needed to know were aware, right? Everything that was done, that was needed to be done, was done. However, the patient still fell. It's a big difference than if you assess the patient and you determine they're a fall assessment, a fall risk, and you do nothing. And you do not put interventions in place, you do not write a care plan, you do not notify those who are caring for the patient that they're a fall risk, then you are liable, right? Safety improvement strategies, preventing falls, targeted solutions tools, TST, fall toolkit, fall prevention training program, so the staff must be trained as well. Root cause analysis. So, any event that a fall occurs, an incident report or event report is completed, and that is mentioned in this paragraph. Um, so, the facts are documented in reference to the incident that occurred. This incident report or event report is not part of the legal record. Okay, it's an internal documentation for the facility, and it should not be written in the nurse's note that an event report was completed. Okay, you do not want to indicate nurses' names, physicians' names in this nurse's note. You just want to write the facts about what happened with the event. You found Mr. Smith on the floor. He was alert, awake, orientated, range of motion within normal limits. However, you do not add in that an event report was done. Okay? So this event report is a document that the facility uses to track the incidents. And on page 863, on the left-hand side, it talks about a confidential document formerly referred to as incident report, which objectively describes circumstances of the accident or incident. The report also details the patient's response and examination and treatment the patient had after the event or incident. The nurse completes the event report immediately after the incident and is responsible for recording the circumstances and effects on the patient medical record. The safety event report is not a part of the medical record. Know that. The safety report is not a part of the medical record and should not be mentioned in the documentation in the medical record. So by law, if in fact this ever went to court, then the attorneys would need to request the incident report. Okay? And the incident report may have statements from everyone that witnessed it or was involved in caring for the patient. However, in the note, you are not writing the nurses or the CNAs or the doctors' name. Well, you couldn't mention that you notified Dr. Smith. However, you're not writing the names of the individuals that were working with that particular patient on that particular day. That would be in the event investigation. So all that to say that they're using this event report. An investigation is done by administration to determine the root cause for this particular incident or event. Okay, and that's our root cause analysis, or RCA. Patient's outcome for safety. Identify real and potential unsafe environmental situations. Safety measures in the environment. Use available resources for safety information. Incorporate incident prevention practice into ADLs. Remain free of injury. Orientating the patient to their surroundings. We talked about this when they come to a new facility. You want to orientate them to their surroundings. And there was a list of things that the nursing staff should make sure that they go over, and that's on page 857. If you recall, I talked about the call bell or call system, adjusting the bed, side rails, etc. It's on page 857. Preventing falls in a healthcare facility. So you want to know about those nursing interventions, which is on page 858, right? They will help to prevent falls. Use of restraints in a healthcare facility. There's two pictures on 859 that I did not mention at the top. So, and it talks about restraints usage. I know you guys did learn this in lab with Miss Gibson. So the purpose of restraints are to help prevent the patient from being harmed. Restraints should not interfere with physical function by impairing circulation. So the picture shows them sliding two fingers under the restraint, and you must be able to get at least two fingers under there to make sure that there's proper circulation. And there may be an order to release the restraint periodically to check for the skin integrity, right? Make sure there's no skin breakdown, and to allow for movement and circulation, okay? So I did want to mention that side rails may be considered a restraint, especially if they are full side rails or half side rails. If anything that prevents the patient's independent functional ability is considered a restraint. So if they're able to normally stand up on their own, and this chair that reclines, such as a jury chair, prevents them from doing that, then that is considered restraint. Or a wheelchair with a seat belt, if it prevents them from standing up, if they cannot unbuckle that seat belt and stand up on their own, it is considered a restraint. If they have side rails that inhibit them getting out of the bed by themselves, it is considered a restraint. So we have different length side rails. You have quarter side rails, which are usually used as enablers for bed mobility or positioning in the bed. They are usually not considered a restraint. And then you have half side rails and you have full side rails. With the half side rails and full side rails are usually considered a restraint. In the event that the side rails are being utilized for bed mobility or positioning as a positioning device, then it must be documented that way on the plan of care, and it should be in order for it in the chart stating two side rails up for bed mobility or for positioning or as enablers. All right, so physical hazards associated with restraints. Increased possibility of serious injury due to falls, skin breakdown, contractures, incontinence, depression, delirium, anxiety, aspiration, and respiratory difficulty, and death. Okay, so these are all hazards associated with the use of restraints. As you can see, they are quite dangerous, which is why they are ill-advised or very limited use should occur. Okay, we have a question. A side rail is considered a restraint even if the patient asks for it to be raised to assist in getting into and out of bed? Well, we just talked about this. And the answer is false. A side rail is not a restraint if the patient requests that it is raised to aid in getting in and out of bed. Some patients may request that side rail be used at night while they sleep so that they may feel more secure. The patient must be able to raise and lower the side rail on one's own. So I do want to bring your attention to page 860. We have at the bottom, box 828, box 28-7, choosing alternatives for restraints. So I would read through this and be familiar with that. And then at the very top, it talks about A&A stance on reduction of restraints and seclusion in healthcare settings. On this slide is showing us pictures of restraints that have been used for children as well as adults. So you have your wrist restraints, which you guys were exposed to in lab for our adults. For children, you have elbow restraints. And then for the mommy restraint, so you're just kind of swallowing the baby in the blanket. So facility safety begins on page 861. So the first thing we have is fire safety. We have alarm management, preventive equipment related incidents, preventive procedure related incidents. Then we're going into 863, which is filing a safety event report. So I mentioned the safety event report several slides back. On page 863, there's a paragraph in the middle of the page that talks about this event safety report not being a part of the actual medical record. Okay, important to know. Okay, so let's talk about race. So this is a safety for fire. So I know some of our students who were at Norton Square this week, you guys were exposed to race. And those who are already working in healthcare, I'm sure you're familiar with race. So the R stands for rescue anyone in immediate danger. Okay. So in the event that there was a fire, we would rescue anyone in immediate danger and utilize those fire doors by getting everyone on the other side of the fire doors in a central area where they are behind another set of doors that is going to prevent them from being exposed to the fire. So you want to activate the fire code. That's our A, activate, or notify the appropriate person. So we're calling 911, right? Or we're ringing our alarm so that the fire department will be notified. C, confine the fire by closing doors and windows. So the oxygen helps the fire to fuel and to burn hotter. So you want to confine the fire, okay, to whatever area that is there. E, evacuate or extinguish in most facilities. So in the event that it's a small fire and you have a fire extinguisher, it's the proper type, you want to use that extinguisher and extinguish. However, in the event that there is a need to evacuate and this fire cannot be contained, then we are evacuating patients to a safer area, or we may need to evacuate them outside of the building. And in the event that we are evacuating them outside of the building, we are moving the most mobile individuals first. Okay, so those who are able to ambulate will be leaving first, and then wheelchairs, and vice versa. All right, we have a question. Which action is the priority emphasized in the RACE acronym Guide to Fire Safety? A, run to the nearest fire alarm. B, act in a calm manner to prevent panic. C, confine the fire by opening doors and windows. D, evacuate patient and others to a safe area. And the answer is D, evacuate patients and others to the safe area. So our rationale is RACE acronym includes the following priorities: rescue anyone in immediate danger, activate the fire code and notify appropriate persons, confine the fire by closing doors and windows, evacuate patients and others to a safe area. Procedure related accidents or possible errors. So, administering medication or IV fluids. So, errors may occur when you're giving medications to your patient. In the event that this does occur, there's an incident report for medication specifically. So, an investigation will be done. Usually, there'll be some education that ensues or follows that for the particular individual. If there is a procedural defect, then sometimes out of that investigation is just a change in procedure on how we document maybe the insulin that's given so that there won't be any confusion in the future if it was a reasonable error, right? Also, we have our transferring a patient, right? So, transferring your patient from one unit to the next, you must make sure you're giving them a proper report. You want to make sure that your patient is stable, that they are coming down with all the equipment that they need, or if they're coming from another facility, that we have the equipment we need to care for them. So, you want to know the patient's needs and make sure that we can meet the needs. Okay, so any errors could possibly occur between transitioning from one unit to the other or from one facility to another. Changing a dressing, oftentimes these orders change quite frequently. So just being aware of any new order changes in regards to the dressing, that is very important as well. Okay, so you may encounter where someone applied a dressing that maybe was not ordered either because they did not have the medication, so they just applied the wet to dry instead of putting the antibiotic ointment on there, or possibly they were not following the order. They did not realize there was a change in the order and they were going from memory and doing the order in accordance to what was previously ordered. Okay, applying heat to a patient's extremities. So oftentimes this is done by rehab. They usually they have a device where they can control the temperature of these heat packs that are applied. Nursing is usually not doing this any longer unless there is a mechanical one that is disposable. You can kind of just break it and it has a certain limit of heat to be applied. However, we are not taking um, towels or washcloths and heating them up, wetting them and heating them up in a microwave or doing anything like that because that can cause injury. And we often do not use heating pads as well as they can cause injury as well, such as burns. So the event safety report. So I did want to mention, I talked about Sentinel events a few slides ago. However, I mentioned that Sentinel event report was required. This is actually being reported to the state, right? It's being reported to the Department of Health, okay? And then the Department of Health would send back, you know, a response, basically either asking for more information or just a conclusion of what has occurred. Sometimes this sentinel event will result in a visit from the Department of Health, and other times it will not. Okay, so I just want to make sure that we understand the difference between a sentinel event and an incident report. Incident report is just a occurrence that is of an unusual nature, not our regular routine. And so a fall is something of an unusual nature. That's not something that we expect to happen on a routine basis, right? But getting up and eating and getting dressed and bathed, those are routine things that we expect to happen, right? So incident report is done, safety measures or interventions are put in place, and we move along with our day. A sentinel event report is done, investigation is done, interventions are put in place. However, this is reported to the Department of Health, and they have to get our stamp of approval on this particular incident, the sentinel event that occurred. Okay? And sometimes that results in a Department of Health visit. All right. So safety event reports must be completed after an accident or incident in a health care facility that compromises safety. Describe the circumstances of the accident or incident, details the patient's response to the examination, the treatment of the patient after the incident, completed by the nurse immediately after the incident, and it is not part of the medical record and should not be mentioned in the documentation. So I mentioned all of that several slides ago. Health teaching in schools. So you want to monitor the child's use of internet, get involved in school activities and ask pertinent questions, volunteer for safety committees that include staff and parents, ensure the school's safe emergency preparedness plan is current. Okay. Emergency preparedness plan begins on page 855, and safety in school begins on page 863. All right, maintaining emergency preparedness. It begins on page 865 through 870. And on table 28-2, which is on page 866, it talks about biological agents of concern, their clinical manifestation if in fact you were exposed to these agents, and the treatment and protection from these particular agents. So each of these bullets have a paragraph that explains exactly what they are entailing. Okay. So again, it begins on page 865 and goes into page 870. Please read them. So chemical use for mass destruction includes metals, nerve agents, organic solvents, riot control agents such as tear gas, toxic alcohols, and vomiting agents.